everyone, and welcome to the fourth quarter of the CTSC's Big Data webinar, TriNetX Database Advanced 1. I'm Dr. Ashley Hughes, and I'm joined today by Dr. Craig Jarrett, and we're excited to present this third piece of our TriNetX Database webinar series. And so without further ado, since we only have an hour together today and lots of information to cover, let's go ahead and get started. So our agenda for today, we will discuss and share with you information for upcoming Big Data Informatics webinars. We'll also spend just a few minutes covering some refresher items from our past two webinars on key aspects of TriNetX. But we want the majority of today's talk and webinar to focus on comparing outcomes between cohorts. We'll cover aspects of how to do propensity score matching for more even and balanced comparisons between cohorts within TriNetX. We'll also cover doing more advanced analytics, such as Cox Proportional Hazards models, and how to request your own data sets from TriNetX. If at any point you have a question, while we do have an open forum for questions at the end, I encourage you to use the chat to drop your questions in as we go along. So for our future big data events and webinars, so this is the third webinar that we are conducting on TriNetX, yet we still have at least one more that covers the second aspect of advanced analytics that you can do within TriNetX, because there are so many options and opportunities to work within the TriNetX database. We have that scheduled currently for 2026 quarter one. February 18th, there'll be more follow-up emails from the CTSC regarding registration details for this event. And we are planning to hold another big data webinar in quarter two, 2026, that helps you compare and ultimately decide which of the big databases are more appropriate for your research and your research question based on the pros and cons of using each, right? There is no such thing as a perfect database. So it's important to proceed with what works best for you. So to jump into some refreshers for terminology and navigating the TriNetX database, we did cover in quarter two of this year how to get access and log in, how to begin forming a project where all of your cohorts and analyses are located, and some of the aspects involved in performing simple queries. In quarter two, our last webinar, we performed a TriNetX Intermediate Database webinar where we dove into aspects involved in performing more complex queries, including looking at patients or diseases over time and different data visualization techniques that are available within the TriNetX database. So as a very brief and quick refresher, the TriNetX database is an amalgamation of different types of data that are available, including different data sources that cover health data, including a large repository of electronic health records, along with claims and pharmacy data. There's also cost data that is available alongside patient demographics, procedures, lab values, as well as vitals. This covers about 7 years, 1.8 million providers, and the latest estimate, although this can change daily based on who is contributing data to TriNetX, about 117 million patients in the US, with a global network of about 275 million worldwide. Unfortunately, if you are based at the Cleveland Clinic, they do not currently contribute data to TriNetX, and therefore you would be unable to have direct access to the TriNetX database. However, there is great partnership among the different health institutions. So if you have a colleague at Metro Health or university hospitals, or you happen to be based at one of these health systems, these are just, again, a reminder of how you go about gaining access. So if you're at Metro Health, you put an IAM request through the MIV on our local intranet site, and then university hospitals, there's a REDCap form that you would need to complete. So our research question from our last TriNetX database webinar was modified to look at what was the percentage of adults by race in the US with essential hypertension that were prescribed an antihypertensive medication. We went into the TriNetX database in order to define a project, and we defined a cohort using a combination of ICD codes to have must have or our inclusion criteria within the global network, which I think in this case should have been the US network, and cannot have. So in this particular worked example, we specifically within the ICD-10 grouping variable, this had several ICD codes contained within it, and that you can expand and better refine selection of who is and is not in your cohort. As this grouping variable includes both gestational or pregnancy-induced hypertension, as well as preeclampsia. Our study was not focused on pregnancy-induced hypertension, so we actually excluded patients who had those ICD codes. So getting to the bulk of today's presentation, I have some screenshots as a backup in case our live demo doesn't pan out as planned. As a reminder, this is sorting through 275 million patient records and claims related data every time you hit a run button or update an analysis. So while TriNetX does a great job of sifting through that for more real-time data of real world data, sometimes it can get stuck depending on how many people are using or accessing the network at that given time. So revisiting our research question, we initially were asking what was the percentage of adults by race in the US with essential hypertension that were prescribed an antihypertensive medication. We needed to exclude some people who were grouped with the overall hypertension diagnosis. And so that we can do some cohort comparison, we've modified this research question slightly to really explore the cohort, which you really need to do before you begin looking at cohort-related outcomes. So this is worded in a more exploratory way, but in what ways do patients diagnosed with hypertension who are prescribed an antihypertensive medication differ from patients diagnosed with hypertension who are not prescribed an antihypertensive medication? And for our live demo, we will be doing cohort comparison of must have, cannot have. I'll show you briefly as a reminder how to copy and paste your queries. And our end goal here is to create 2 cohorts to compare. So let me pull over our TriNetX. So let's see, hopefully are you all able to see my TriNetX landing page? I hope that I've shared this correctly. This is my screen. Okay, so this is your project or your home landing page, and we have some worked examples within the Big Data webinar, TriNetX Database Advanced, that Craig and I have shared. So when you open this will have all of your analytics within your project. This will be shared with whomever you've granted access, and also have all of the different queries that you can contain. So I'm going to just show you briefly here how we go about creating a second cohort. So if you recall, we had hypertension with treatment. So let me pull this up here so you can see just how we had defined this group. And while I have a second cohort already identified, so this can be a little misleading. So when it goes to create a new group, this is not referring to creating a new cohort. You need to actually run a new query. This is really a group that you can create within a cohort and not for creating a new cohort altogether. But we're going to go to the new query and just know that you can import a query since this is really similar to our hypertension group with treatment versus without treatment or without that prescribed antihypertensive. I just imported the query. Since I technically already created this, I'm just going to show you what it looks like. So I imported the query, and what I did is instead of including people with who had been prescribed an antihypertensive, I actually moved that over to the antihypertensive as an exclusionary term. So We have two cohorts created, and you'll see that this is a cohort of 20 million patients, which we'll talk about more when we're comparing the cohorts and their different characteristics. And as a reminder, too, as you're defining these things, it will also show you how many healthcare organizations this represents out of your overall network. So we are now going to, now that we've created two cohorts that appear, we've got hypertension with treatment and hypertension without treatment. We can now jump over to our analytics tab that lets us begin comparing characteristics of these cohorts. So I'm going to go to new analysis because these are all the saved analyses of what Craig and I have been working on over the past bit on these examples. But you'll see here it says single cohort, single cohort. They kind of give you a preview of what types of comparisons you can do with each of these analytics. There's compare cohorts, which is what we can do now. But there's also compare outcomes. And what I like about it's nice to have both of these. If you either way, you need to compare your cohorts before you do any sort of outcome analysis. But as we are going to be comparing outcomes actually gives you access to the same features that you would need to compare your cohorts anyway. So we're gonna jump into compare outcomes here. So here are where all of your cohorts appear. So you essentially drag and drop what you want to be considered cohort one versus cohort two into the subsequent, the corresponding columns. So let's see, we've got a few of them here. So we'll do without treatment and then scroll back down for with treatment. Okay, and now we're going to go to characteristics. In this case, this is where it does differ between the compare cohorts and compare outcomes for cohorts, and that you need to set an index event, or essentially what is the defining characteristic of people for them to essentially be included in your study. I'll say this a few times that TriNetX has really some wonderful embedded statistics that can make your study more robust. And so in this case, it's got, really some best practices for conducting quasi-experimental, more observational, retrospective studies, which we'll talk more about with propensity score matching.
Taking a gamble, seeing how long.
Yeah, we are. Yeah. I hold my breath a little bit every time. And I'm pulling out, I've got my slides over here for the cheat sheet, just in case.
Yeah, it really depends on the time of the day. Much like Cosmos, if you're running it, I ran some late last night and it ran better. Although, um, and I'll show you the limitations with when I do the Cox Proportional Hazard. It it doesn't, although there are hundreds of millions of patients for some of these analyses, you can't use that many.
Hmm.
In the system as it stands, we are going to show you how to request data sets. So you could potentially request the data set and do it on a more powerful, with more compute. But and the while this is going, the one difference between this and Cosmos is Cosmos has a comeback. It's called come back to query. And so just in this scenario here, there's a little save button, or
Hmm.
it's a feature where you hit a button and it goes in the background and you continue working, and it will save that query whenever it's done, no matter how long it takes. What I've ran into quite a bit with TriNetX is there is no feature like that yet.
Hmm.
And it will simply just log you out after about a half hour and the query is still going. So,
Yeah.
um, oh, there.
Yeah. That's fantastic, Craig. And I just put some of that information in the chat because I think TriNetX, right, doesn't have that feature just yet, but it is such a useful tool. Oh, hey, look, we might actually get results. I was about to launch our slides here. But it's so nice to be able to do the live walkthrough with you all. So, yeah, and thanks for that. that input there, Craig. The first thing that you can tell, so if you recall from our last webinar, where we were exploring a single cohort, you're going to get those same tabs and those same features, but you're going to be able to compare across cohorts. And I do like that this is color coded. The first piece that we'll point out here is that our group, our cohort that we defined as hypertension without treatment is significantly larger than our group of patients with a diagnosed hypertension that have been prescribed an antihypertensive, or what we're calling hypertension with treatment. And you'll see within the demographics section, right, you can kind of get at a glance, kind of what might be happening, how comparable some of the groups are. What this does not do for you automatically is show you if these groups are significantly different based on the outcome, or if like these characteristics are influencing your outcome. But what we can do with any characteristic that may be of interest to us based on theory, evidence-based medicine, or I mean, sometimes you want to limit it, but just out of curiosity or what the data may be telling you, we can actually flag some of these characteristics that we may want to explore or dig deeper into the data to actually test that assumption of whether or not these are meaningful differences. So I'm also going to flag here Black or African American. We've got race or ethnicity that can, potentially influence outcomes. Now, I'm just going to point out over here that each time I save one of my demographics, or you can actually do this throughout each of the tabs, and I, again, encourage you to go through each of these, not for the purposes of saying these things are distinctly different, but to give you an idea of what some confounders may be in how your groups may differ from each other. And this is going to be really important here in a minute. So I'm going to go over to diagnoses, but it's keeping track of what I have starred as potential confounding variables. Okay, now this I do really like because you do get a bit more of a sneak peek here with TriNetX Signal. So Signal is essentially showing you how these groups may differ and how much they may differ if it seems like they are very different. So we're looking and we can see at a glance, right, symptoms, signs, and abnormal clinical findings, not elsewhere classified. These are all really high level groupings for diagnoses, and the same goes for procedures and medications for any of them. They're really grouped at a very high level. But what you can do, and you can basically, I'm just going to show this and hopefully it won't take too long. But you can drill down into each of these and look to better specify, kind of help you refine your cohort essentially, and help you refine how you may want to approach analyzing your data so that you're making more fair comparisons between your cohorts. So, just this as an example, right? These are still fairly broad diagnostic categories, but you can tell, right, even though this overall had like one bar for the signal, with where the increasing bars means that they're more different, it varies greatly based on which category you're exploring. Now, I kind of drilled down over here into mental, behavioral, and neurodevelopment disorders, and I see that on the whole, there seemed to be something going on in this category. So this is where I sort of focused, just out of exploration and wanting to look at differences between these cohorts, began identifying where things may be different. So in this case, I think mood and affective, we can look at mental and behavioral disorders. And again, you can drill down to be more specific here. But again, I'm just trying to be conscious of our timing together today and show you some of these key features within TriNetX. So I'll specify those, I think, for now. We'll do some personality disorder in there. And I think we had, yeah, substance use. Okay. Now, again, you can go into each of these, and I encourage you to do that, especially to look for things that may be clinically relevant or meaningful, as well as anything that you think based on prior work may be important to look for differences. Now I'm going into my saved characteristics here. And that's where TriNetX has been tracking and has stored everything that I've placed a star next to. it's taking a moment to think about it, which is fine. Right. And then it just has this list for me here. And really, when you're doing just or using just the cohort comparison tool, you can do the baseline comparison characteristics. So what, and again, I think this is why TriNetX in their embedded analytic features are really fantastic, that you can actually do some significance testing for any differences before you even run propensity score matching or try to do controlling for confounders between your groups and match your control and treatment groups accordingly. So we are going to try to run this, and emphasis here on try for the purposes of the live demo, but also, so uh, this is, I believe, what Craig was alluding to earlier in that TriNetX database, right? This is a very large combined cohort. We're asking a very broad research question, and it's telling us that we can have zero covariates. So this is TriNetX way of saying, hey, nice try, but let's try again with a smaller number of people.
And
So,
and this may, depending on when you run it and the the load on the server, this may or may not pop up. So I've run the same query. Sometimes I get it, sometimes I don't. So again, but you get the point. It's like you can't even have, you can have no covariates, right? So again, maybe an opportunity where you request a data set or change the population you're starting with.
right. So again, for the purposes of illustration and in our example, in this case, we're going to go back to our cohort definitions and we're going to try to refine that group, particularly the cohort that had 20 million patients in it of hypertension without treatment. So I also encourage you to take note. I mean, you can use some of the features we talked about in the intermediate webinar of like copying and pasting some of your output of cohort comparisons or just jotting down some notes of how your cohorts may differ, just so that you can use that information to then refine your query. So let me see. So I actually named this. This is a cohort that I pre-worked so that we could get this. We could compare some at least one baseline comparison, in that I excluding people with mental and behavioral disorders due to psychoactive substance use. That was something that showed up in the signal as having differences between those groups. Mood or affective disorders, other forms of heart disease, right? Like people who have, we're not sure if the people who have, if what we're calling people without treatment or who have not been prescribed an antihypertensive, if they have other cardiovascular risks or diagnosed cardiovascular diseases. So we have those excluded again, just to get our cohort to a more manageable size. In this case, this brings us down to 10 million. So still very large cohort, but this just gives you some examples of how you can use that output to help you refine your inclusion exclusion criteria. So now we're going to jump back over to our analytics. Because now we have a different cohort that we want to compare with similar criteria. And for this, I am going to assume that I'm probably going to need to go over to my slides because, right, this is going to have to go through everything, the whole process all over again. But we just go back to our analysis page. I'm doing compare outcomes between cohorts. We're going to do hypertension with treatment. And then I've got my cohort that I've lovingly named hypertension without treatment for balance. And we're going to go to characteristics. We're still going to set our index or inclusion criteria as having a diagnosis of hypertension. And we're going to try to run it, see how long it might take. And I will pull up our slides in case we need to refer to them. So I'm hoping that I can, I apologize for the slides in this way. So based on refining the cohort, I could still, because this was still quite large, right? We ended up with about 10 million patients versus 5 million patients. Really only could run one covariate even after refining based on all the criteria that we mentioned. And so I chose Black or African American patients as a demographic factor. I went back to baseline comparison statistics. And what I did is I told it to run to check for any statistical significance or meaningful difference between these groups based on this demographic factor. In this case, right, ideally we'd probably be checking for additional covariates. Just wasn't in the cards based on how this cohort was defined. But this runs a z-score. So it does a z-test for population level statistics appropriately to check for those differences. And if we're running, and it seems to be very significant, at least based on p-value, and just as a note, when we're doing multiple comparisons within this particular section of TriNetX or any analytics, because as we will talk about when we get to outcome comparisons, you can specify multiple outcomes, but it's not going to automatically apply a Bonferroni correction or any other type of statistical control to account for all the comparisons that you're making. So that's just a word of caution, because we want these differences to be meaningful and not be based on a statistical sort of fishing expedition, I guess you could say. So I'm going to see just where we are. It looks like we're 42% complete. Um, I was going to go back to slides anyway. Let's do this and we can talk a little bit about propensity score matching for those of you who may not be familiar with the term or what it means for observational studies. So I love this comparison that's been made. So we know if we're doing a prospective randomized clinical controlled trial, that randomization is key feature for signaling that this is a high quality study and that it helps reduce the potential for confounding variables between our treatment and control groups. So that is for a prospective study. So randomization is to randomized clinical controlled trial as propensity score matching is to observational study. And the more formal definition of propensity score matching is that this is really intended for quasi-experimental research, like what we're doing today with setting an index event and comparing outcomes. But that this is a more robust statistical technique that basically will help identify who is more likely to be in the treatment or control groups and try to match them based on some of these shared characteristics. And so TriNetX will essentially allow you to do this type of matching between your two cohorts with based on key characteristics that you tell it will be important for it to do that matching on. So using this, you can essentially better estimate the impact of what you're trying to study instead of comparing two groups that may be more accurate and fair comparisons between these groups. So I'm going to go back to yes, great, back to our TriNetX, and it seems like it has run our analyses. I am going to go back. So, right, we're looking at these two groups that are relatively unbalanced and not quite fair, at least in terms of size. And we're going to flag some variables that may be of interest. So, in this case, for purposes of illustration, right, we know from our baseline comparison statistics that the racial group, Black or African American, seemed to make a difference in terms of differences between groups. We had tried to run Hispanic or Latino in our last one, but we just weren't able to. TriNetX was not able to actually do so of note, what I'm saving as characteristics, you can still balance your cohorts So we're going to go down to this is usually where at the baseline comparison, this is usually where your ability to analyze your cohorts differs if you are using the compare cohorts analysis tool. But right, as we wanted to talk more about outcomes and balancing cohorts, I'm glad we picked the compare outcomes analysis feature. Right. Even though we weren't able to do baseline comparative statistics and look for statistically meaningful differences between the groups based on each of these characteristics, we can still, if we have an informed hunch or hypothesis, or we know based on prior evidence that something is a potential confounding factor, we can still um, account for it with our propensity score matching. So you're less limited in terms of what you can account for with the propensity score covariates. So we're going to run this and hopefully, hopefully it won't take too long. What I really like is you're going to get a decent sense once this is done running of kind of a preview of before and after you match or try to balance your cohorts based on your pre-specified criteria. So not only are you going to see kind of what your propensity score matching looks like, but you're also going to see, at least at a very high level glance, what it's doing to your groups. And sort of be able to tell, okay, assess for um, uh, is this, how is this, especially if you're looking at a rare disease, how does this sort of limit my ability to interpret? How is this actually kind of helping the groups pair better together? And you can even, as we'll get into with outcomes, you can run your outcome analyses um, with and without matching. So just because you're running propensity score matching does not necessarily mean that you have to use them in or control for them in your actual outcome analysis. So you can see here before matching, there were some overlapping lines in the propensity score, and after matching, they were kind of more along the same line. We see that we see the number of patients before matching, right? That there were slightly more patients in our hypertension with treatment or that antihypertensive medication, and that number went down slightly after matching. But we definitely see a big reduction in the number of patients in our second cohort of without treatment for balance, that it went down to 5 million. But it is likely better that you're able to have fewer people in the comparison so long as they're more apt for the comparison. Patients with hypertension and diabetes, treatment and non-treatment. We could absolutely make that comparison, Dr. Liu. But we would definitely need to refine our cohorts for that. And we would also need to get into the weeds. So I'm just reading this comment from the chat. Can you please compare patients with hypertension and diabetes, treatment versus non-treatment? Right. Depending on what you're considering to be treatment, right? Are you talking about diabetics who are insulin dependent and therefore have some type of, you would have to specify sort of what treatment means for diabetes, and what treatment means for hypertension. And, would that be two cohorts? Would that be four cohorts? And again, just as a kind of friendly reminder that you can sort of do two cohorts at a time. You can do multiple comparisons, but TriNetX does not have a built-in feature for correcting for multiple comparisons and the biases that can introduce. I know we've also got some content that Craig will be covering today as well. So I'm going to go ahead and go on to exploring our outcomes. So in this case, right, we've already identified our set index event. We're going to run. and we'll look at outcomes.
And there's nothing stopping you here from doing, like we're looking at a binary outcome. Either they have an event or don't. And there's nothing stopping you from just doing multivariable logistic regression from the beginning. But it's always better to get, since you know that we looked at the demographics, we looked at the characteristics, and the patient populations are different. It's better to match them and then do your regression. So that feature is obviously what we're trying to show here. The one thing while that's running that this doesn't get to is it is, do they have an event or not? But it doesn't take into account the exposure over time, right? So just looking, if somebody is on an antihypertensive versus not on antihypertensive, are they going to have an event? Well, it depends really on how long are they at risk of that event based on the exposure. So that's what we'll get to whenever this completes.
Yes. I'll give it a few more minutes. I'm wondering if there are additional sort of questions or comments that you all have as we're waiting. Again, I enjoy doing the live run through. Just it's obviously an imperfect system. I am going to try restarting my slides with those screenshots. We'll check back in on this in a minute because just because we've specified our outcome, our index event does not necessarily mean that we've specified our outcomes yet. So right, see, is this, here we go. Propensity score matching results. We've looked through that. We're going to be selecting outcomes. When you begin selecting outcomes, you have the ability to compare cohorts before matching or compare cohorts for after matching. And despite this being selected here in my screenshot, we actually ran this doing compare cohorts for after matching. When you are selecting outcomes, so you have to say that you want to add an outcome, so new outcome here. And this is moving along. That you then get several different types of measures. You have the ability to define your event. As Craig mentioned, we will actually be looking at whether or not these cohorts experienced differ on their experiences of a stroke or a heart attack as our events. And so we're selecting measures of association. However, you can see here that there are different types of tests you can run. And you can also name your outcomes. You can, let me see if this is in the next slide. I believe it is. So we've selected measures of association. And in this case, you can either go through your results after you run the index event, right? There's usually the tabs that appear in the left-hand side on the TriNetX analytics page. You can star your outcomes. In this case, I searched for cerebral infraction, which is stroke, and ran measures of association. And I do have that analysis pulled up on the other tab, so I can monitor that as we go along. I added a new outcome and we did heart attack or acute myocardial infarction and measures of association again that we could get some odds ratios. And again, we were comparing cohorts after they've been balanced. So when you run this analysis, it's going to recompute your propensity score density function. So again, before matching, we were seeing some odd differences in terms of the outcomes of interest for each of our outcomes. So that got cleaned up a bit with our propensity score matching. And we're able to see this was I think, fairly interesting to me that it shows each of your outcomes as a separate, you can tabulate to go back and forth or just scroll down. You can also sort of group your outcomes or your analyses based on whether you're doing like measures of association versus frequency counts for those outcomes. So you get your risk, you get your number of patients with the outcomes, you get an odds ratio. So in this case, greater than one. So we know that there is an odd of the or greater odds of one, greater than chance for the event to happen. And interestingly, our group of hypertension who's been prescribed an antihypertensive has a greater risk of incurring a stroke. And then when we look at heart attack, it's a very similar with actually an even higher odds ratio of incurring a heart attack. And so how at least I interpret that, even though I'm more of an informatician and less, not trained clinically, what that means to me is there might be something other than the treatment that might be driving that change. Maybe they've been prescribed an antihypertensive because their hypertension isn't being managed. And, this to me also raises more questions of what else might we want to control for or add to our analysis to make it more refined. And sorry that we could not. Yeah, and so you can select specific outcome measures. So, Craig, I know we gotta jump over to you soon. Do I have time to kind of answer that question? I've got
Yeah.
TriNetX over here.
Yep.
Okay, so let's just jump over to outcomes, right? Compare cohorts before matching. I just wanted to show the follow-up time, select outcomes. So when you're doing select outcomes, right, we have an unnamed outcome here. This is all part of the same interface. We're in inputs and we don't have results yet because we haven't run it. So specific outcome measures. So these are measures of association, or if you just want number of instances. So let's say that maybe I think one when we were Craig and I were talking about different examples for this, I was thinking of, maybe it's not it's being a little laggy. Um, but I was thinking of maybe like emergency department visit. What's the likelihood? Could be a likelihood, could be just the number of, do people who I'm just going to choose this one, SNOMED. SNOMED isn't always used across different sites, so it's not super great. Let's just do number of instances if it will allow me. Sometimes it's a little laggy. And then you can, kind of run that. So, you have a host of different outcomes that you can look at and run for analyses. And I think just based on where we are time-wise, I do definitely appreciate the questions and, kind of, I think it helps showcase the flexibility of how you can use TriNetX. But you can explore lots of different types of outcomes in different ways. And you may realize, as we did, I think this is just part of developing a query that sometimes you need to go back and account for something else in your analysis, as you go through the process of interpreting and working with your cohort definitions. So I don't know that we're going to get the output from this. Just due to time, so I'm going to stop sharing here. But yes, you can use specific outcome measures. It just depends on what you want to know, and there may be some things like relative to lab values that you may not have direct access to, or you may want to control for. But it really depends on the specific outcome that you're interested in. I hope that helps answer the question. So I'm going to turn it over to Craig, who's going to talk a bit more about our Cox Proportional Hazards models and how to do those within TriNetX.
Okay. So I'm not going to go too much into the query builder because we already have been through that. But in the same project that Ashley was in, very similar cohort, except again, it's a little bit of a trial and error. You'll run these analyses and you'll realize, oh, it timed me out. I've been waiting a half hour and then it logs out. And, I'll sit there and you can fiddle with the screen and it shows that kind of that arc graph. It will not register your input when that is showing. So anyway, through a series of many trials and errors, I had to change the cohort to limit the number of patients. So initially we had all adults, so 18 and above, way too many patients. I did 65 and above, way too many patients. It just kept closing and closing. So I had to alter the patient population to just 65 to 66. No heart disease, no mood disorders. Again, I was looking for things that could potentially change the outcome, or that there were a large number of patients, just so that we could show how this works. And so I ended up adding a bunch of additional exclusion criteria to limit the population down to something reasonable like 60,000. But this is a hypertension with treatment, and then a very similar hypertension without treatment, except now we have no antihypertensive. So we've already been through all these. It's the same. So you can go through and you can explore and analyze, and summary statistics, all the same. We're going to skip right to analytics for this one. And I'm going to do, as this was new, although we've already run it, it takes a while, so I'm not going to actually do it. But the other analysis that we're going to look at is the Cox Proportional Hazards Model. And so what Ashley has shown you is the compare cohorts that's looking, basically at the baseline statistics, although you can look at the outcome events too, comparing outcomes, the two cohorts. And as you saw, you get an odds ratio from this. You can also, we didn't click it or show you, but you can do Kaplan-Meier curves and get log rank tests, right? But those are still making a lot of assumptions that the patient populations are the same. So can you see if a Kaplan-Meier curve is different? Yes, based on the log rank test, you can see that the Kaplan-Meier curves for event rate of a stroke are different. And we did match these patients. So that's not an entirely crazy analysis to do. But if you really want to look at the patient risk over time, then the Cox proportional hazard is the way to go, because some of these patients never experienced the event, so they're right censored. Some of these patients have been in the cohort for 20 years, right? And so maybe they're hypertension with antihypertensive for 20 years and they experience the event. It's very different than a patient who's been in the cohort for 1 year, right? And is not on antihypertensive. And so this gets to a better comparison. So very similar interface, Cox proportional hazard, you drop in your cohorts just like you would for the other ones. These are already built, right? You can go to covariates. You do have to pick your index event. And for this, our index event is, did they develop hypertension, right? That is the index event. The exposure is hypertension. And then you can include covariates here. So you can add whatever covariate you would like. Again, having done this through trial and error, I couldn't put any in or it would just not run. So again, another reason to streamline your cohort, make it smaller, maybe not include the data from the entire historical record, but over the last couple of years. There's a bunch of ways to limit the cohort size, but you can include, they have a couple here that are, you can just check, or you can add really any covariate that you can think of. We're not going to add any. The outcome that we're adding is I did a heart attack, so it's pretty easy. It's just a myocardial infarction. Put that in. And again, these are groupers, or they're ICD codes. So if you do I-21, that includes I-21.1, I-21.2, etc. So we do that, and then you have to add that to the query. And then you run this. I'm not going to do this. I already ran it. It takes forever. And so I'll show you the results. And again, now this tells you what the instantaneous hazard or the instantaneous risk is of having a heart attack in one cohort versus the other. And so that instantaneous risk or hazard ratio is almost 2. So what this shows is, and again, these patients aren't, this is a Cox proportional hazard. This is not propensity matched and then subsequent logistic regression. This is a completely different method, but it shows that the instantaneous risk of being a patient with hypertension not on treatment is almost two. So is twice as high of having a heart attack compared to patients who are on treatment. And so this makes a little bit more sense of what you would expect, right? Because in the analysis that Ashley did, it doesn't take into account, it's just did it happen or not, but it doesn't take into account how long the patient has been exposed to that risk, and which this does. And so that is Cox proportional hazard. I'm going to move along to requesting data sets because we keep saying this, like, you can't do this, you can't do this. So again, the fixes are you just limit your data set to a couple of years because right now we haven't done that. We've just used all data available. That's probably the cleanest way, and it's a quick change. The other thing that you can do is you can request a data set. And so the way you typically do that is on the query builder screen, you have to have procure data set permission. I don't. Actually, I don't know if you do, but when you click on a data set, this yellow, if you have, and you can, I haven't requested, I don't really request data sets from TriNetX. I would tend to use Cosmos, but if you have a procure data set permission, then when you click on this turns yellow and instead of the pale unactivated button, and you can request that data set. That data set will then show up after it goes into the pending, and then once it's approved, it'll be in the available data set. If you don't have, and even if you were to request to get procure permission, you probably wouldn't because it may require some data use agreements. And there's usually, I know at UH, there's one group of people who have that access and they would do it on your behalf. And so you can either, there's two ways. You can either, if you know who that person is, it's Michael Baker's group in the Clinical Research Center. You can email, it's biostatsupport@uhhospitals.com or .org. Or you can, in this design assistance, you can put a request here that will go off to the admin for TriNetX at either UH or Metro, and as well as the TriNetX staff, and they can help you get that data set. So those are the two ways to get the data sets. And again, then you can, if you get the data set, you can use more compute and you can likely do some of those complex analyses that we couldn't quite do on here. That leaves us about 6 minutes for questions.
And I have been trying to refer to some questions in the chat. And one of the questions I think is that's worth mentioning to the group is what is the common way to prepare the finding to publish? And so I think to that question, there's not really a tried and true answer to that, other than it really depends on what you're wanting to do versus what the TriNetX platform will allow you or enable you to do. You obviously want to choose an approach that's going to be best based on your research question of interest. And I know we mentioned this, I think, in the very first TriNetX data webinar, but I think it bears repeating that it's with such large data comes big responsibility, which is the name, big data comes big responsibility is the name of a study Dr. Kalber published and others who work with TriNetX and large data sets very regularly, that you really want to, it is just so easy to get access to this data and it's so easy to find statistical significance that it really, again, bears repeating that you need to refine the question and refine your subject of interest so that you're taking a very targeted approach to understanding and getting the outcomes or comparisons that are most meaningful based on your question. So I put a file in the chat that just shows It's just I mean, you can find multiple published manuscripts that have used TriNetX. And then I can also share Dr. Calver's publication on, kind of best practices for using, they use TriNetX as an example, um, kind of best practices for going about publishing this type of work. Did you have anything to add to that, Craig?
No, just yeah, that you can always find something statistically significant in this data because the confidence intervals are so small, but that doesn't mean that it's clinically relevant.
Right, exactly. So I put the link in there and shared a PDF. Um, and the great news is, so also just as a friendly reminder, I know Laura and others from the CTSE remind us of this all the time, but if any of this has been useful to you, you end up finding some good collaborations or get like a paper or even a conference abstract with students together. What's really nice is that you learned about this through the CTSC. So yes, absolutely. You'll receive a recording, the link of the recording to this meeting, and I included links to our prior recordings in the slides as well. Um, and so you just make sure that you cite the CTSC grant because that's where our support comes from to do this. And what I personally, I'm biased here working with CTSC, but I personally like citing the CTSC grant whenever I can because per NIH publication rules, that now has to be open access. So that means even more people can access the work that you've done. And that also means that you may be more likely to be cited or can share your work on ResearchGate and more readily, right, without having to pay those open access fees. So that's my little CTSC grant citing research hack. And I hope all of this was useful to you. Are there any other questions? We do hold, again, I mentioned this in the beginning, we do hold like a monthly office hour. That will resume in February, because we'll be on holiday break. Thank you guys for attending. Hope this was useful. And so our next webinar, we'll be holding one February 18th for TriNetX Database Advanced Part 2, and we'll be holding office hours February 4th. Yeah, thank you for sharing that link, Laura, and thank you all for attending.